Hello, everyone. Thank you again for joining us. It's 11 o'clock on the dot here, so we're going to get started in just a minute. First, I'm going to mute all of our lines, and then we'll begin our webinar session today. So let me mute our lines right now.
The leader has muted your line. To unmute your line, press #6.
Okay, Stephanie, are you there?
Yes, we're here. Can you hear us?
Yes, you sound great.
Perfect. Well, good morning, everyone, and welcome to our webinar. In many regions across the country, providers are partnering with community-based organizations to reduce readmissions for patients at high risk of readmission. Services focus on providing outpatient care management for patients whose complex physical, behavioral, and social needs may not be adequately met through the current system. Today we're going to learn how Signature Health Brockton Hospital's community integration team is enhancing care to reduce readmissions. This effort is supported by funding from the Massachusetts Health Policy Commission's Community Hospital Acceleration, Revitalization, and Transformation Investment Program. Before we get started, I'm going to quickly review a few housekeeping items. The call will be recorded, and the recording will be available within a few business days on our website. Phone lines will be on mute while the speakers are talking, but we will unmute the lines after the presentation for questions. I'll give some instructions on how to ask questions at that time. And just to be safe, please also manually mute your phone. Although the lines will be muted, we still would like you to actively participate during the session by using the chat function. My colleagues, Nancy and Nayara, will be monitoring the chat window and responding to your comments in real time, so don't be shy. We'd love to learn more about your efforts and how we might best support you going forward. And we'd also love to hear your thoughts about what the speaker is saying. So first, we are going to start with a chat right now. So let's look to see who is on the call. Please type in your name and role, your organization, and the state you come from. Dr. Parsons, Signature's Heart Program Coordinator, will share how they engaged over 40 partners to support this community effort to explore how addressing behavioral and social needs has complemented their medical model, making a critical difference for their patients. She'll also describe the challenges and key learnings the group encountered along the way. Before we get started, too, I wanted to share that this work was funded through Massachusetts Health Policy Commission's CHART program. The Health Policy Commission is an independent state agency that was formed by the Massachusetts Cost Containment Law in 2012. Health Policy Commission monitors reform in healthcare delivery and payment systems. Health Policy currently has 2 investment programs, one of which is CHART, the Community Hospital Acceleration, Revitalization, and Transformation Investment. The CHART program is being implemented in phases, and during the first phase, the program focused on activities aimed at promoting system transformation. And during the current phase, the goal of the program is to promote care coordination, integration, and delivery transformation, advance electronic health records adoption and information exchange among providers, increase alternative payment methods and accountable care organizations, and enhance patient safety, access to behavioral health services, and coordination between hospitals and community-based providers and organizations. Today, we are going to focus on one of the CHART Phase 2 projects. We'll learn about Signature Healthcare Brockton Hospital's program, which leverages a community integration team to enhance care coordination and reduce unnecessary hospital utilization. So I am pleased to introduce Dr. Deborah Jean Parsons. Dr. Parsons is an experienced professional in the fields of children's mental health, social services, and healthcare in Massachusetts. She's a graduate of Brockton College and the Howard School of Brandeis University, where she completed her research and dissertation on children's mental health services in 2012. Dr. Parsons has worked for over 25 years in program design, operations, and management, having developed and run 2 innovative models of service delivery for children, youth, and families. She served as a consultant for the Association for Behavioral Healthcare and adjunct faculty at Quincy College, Glasgow College, and the University of Massachusetts at Boston. Dr. Parsons is currently the program coordinator at Signature Healthcare, where she is leading a program to reduce hospital utilization for high-cost, high-need patients and decrease patient length of stay in the emergency room, and implement a system-wide culture of safety through a CHART grant from the Massachusetts Health Policy Commission. So now I'm going to turn it over to Dr. Parsons.
Thank you, Stephanie, and thank you for inviting me here to share a little bit about what we've been working on in Signature Healthcare. We are one of the largest integrated health systems in southeastern Massachusetts. We serve about 13 towns. We have the Brockton Hospital and Signature Medical Group, which includes 11 outpatient clinics for both primary and specialty care. We are a medium-sized community-based hospital, but we are also fortunate to have the last standing diploma School of Nursing on our hospital campus. And this is a tremendous benefit for us, not only for the next generation of nurses, but because we are able to offer our nursing students a community health clinical rotation where they go into the homes of our elderly patients who have chronic heart failure or chronic obstructive pulmonary disease, and they conduct home visits. So it's a wonderful partnership with our School of Nursing. While we serve the larger community in the greater Brockton area, most of the patients that come into Brockton Hospital come from the city of Brockton. Brockton is a distressed community which lost its manufacturing base in the early 1970s and hasn't really had a big industry to take its place. In fact, we are the largest employer in the community. We have the 4th largest penetration of poverty in Massachusetts, with a third of our residents living at or below the poverty line. We have a high degree of ethnic and racial diversity, with a quarter of our residents that are actually born outside of the United States. With that comes both linguistic and literacy needs for our population. So with the higher rates of poverty come all of the adverse effects of those, and we have significantly higher than state average rates for all of the many disease categories, in particular our asthma, children's asthma, diabetes, and assault-related injuries, as well as, of course, mental health and substance use disorders. So why we're trying to do what we're doing is, like most systems across the country, we're trying to get a handle on the cost of health care. And when you look at who is costing our health system the most, it's the top 5% of patients that cost almost a half of all of our health care expenditures. And while that might be concerning in and of itself, what's more concerning is that for all of the money we are spending on the top 5%, we are not getting the outcomes that we would want. We're not actually affecting the health of these patients who fall in the top category. These patients, when you look at who they have complex physical, behavioral, and social needs that, as Stephanie said, they're not currently being met through our fragmented healthcare system. The goal is that if we can find services and manage the care for this group of patients, that we will be able to provide efficient, effective care in a way to increase quality outcomes and reduce healthcare spending. Patients who fall in the top 5% have numerous unmet needs, mostly in the bottom 2 tiers of Maslow's hierarchy of needs. They have needs for physiological and safety and security. In healthcare, we call this the social determinants of health. And this means that we have to start with our patients to help them meet their most basic needs before we can help them with their more complex health needs, such as taking their medications regularly and engaging in healthy behavior. It is unrealistic, and I would argue, and others would agree, unfair to set goals for patients that don't match the level of their need. And if we're going to shift our focus to addressing the needs of our patients first, we need a different lens into patient care. Here's where we need to integrate the medical and the social model of care. The medical model is well known to hospitals, but what's less well known is the social model. In hospitals and in healthcare, we know how to diagnose diseases and conditions. We do that really well. Less well that we do is putting the person first when we're thinking about what are the problems that this person is struggling with. And this is the whole move towards patient-centered medical home, and that we really have to be engaging our patients and putting them in the center of what we're trying to do, and not defining them first and foremost by their disease, but defining the person first who has the disease. And this is not just a semantic change. We have to shift our culture from referring to patients as schizophrenic or addicts to a patient who has schizophrenia or a patient who is struggling with addiction. And that matters, not just semantically again, but in how we treat our patients and how they know how we feel about them. In the medical model, obviously, doctors know best. And doctors do know best. But who also knows best are patients. And we need to have a partnership between a doctor and the patient so that the doctor's expertise is considered just as equal as the patient who knows themselves. Obviously, we're focusing on biological and physiological factors. We do lots of tests, x-rays, exams, looking for what's wrong with the patient. The social model challenges us to include in all of those tests and factors and considerations what are the social and emotional determinants of health, which is really how has this patient gotten to where they are? What really is happening outside of the health care that is impacting the health of this particular patient? And then we need to build our treatment plans based on what the priorities of the patient are. Again, we have to match the level of need. The last tier on this comes from trauma-informed care, which is to shift our questioning from what's wrong with you, what's your problem, what brought you in here today, to what has happened to you, which is a recognition that the patients who are coming in with these complex and comorbid conditions, that it is not one single problem that they have, that there's a whole host of things that have happened in their life that has brought them to this point. And we need to understand that if we're going to have better outcomes with them. So what we did for our phase 2 is we put together a community integration team. And this is made up of a nurse practitioner, a nurse care manager, we have a licensed social worker, a community health worker, and a palliative care nurse. This team works with patients who fall in our what we call high utilizer category. And we define that broadly as if you've had 4 or more hospitalizations in the past 12 months and or 10 or more ED visits in the past year. This team works with all the patients that fall into this category unless they tell us they do not want us. So we are an opt-out program. Patients with complex medical and behavioral health needs who are living in unstable conditions did not get into this state overnight. So we work with patients for as long as they need us in order to get them stable in the community. So how we do this is we first have set up an automatic flagging system in our electronic medical record that pulls for these eligibility criteria when a patient registers in the ED. So anyone who comes in and it's their 10th ED visit, we get a flag on them that says TARP, or if they are inpatient and that's their 4th hospitalization, there's a flag. That is sent to our team electronically right to their laptops, and they get a list of patients who fall in that category during the day, and that's refreshed every 15 minutes. We also have a customized database that sends alerts directly to staff. For example, our nurse care manager gets alerts that tell her if somebody has come in during the day. So we identify our patients and then we engage them. Our staff engage patients as part of the hospital care team. We do not tell patients, nor do we consider this a separate program. We don't have consent forms. We don't say this is a big team and would you like to enroll. We basically come into patients where they are in the ED or inpatient and say, hi, my name is Maura. I'm a social worker. I've helped some patients get services and wondered if you would need some help getting some services or resources. And just as part of the other team, the other nurses coming in, we're just part of their team. We find that we have a higher engagement rate because it's more consistent with the way the hospital operates, and patients are used to people coming in and asking them how they're doing and what kind of help they need. Once we have engaged our patients, we meet with them. We either call or meet with them in person within 48 hours of discharge, and we conduct home visits on all of our patients. Now, that doesn't mean all of our patients have a home, which means we are going to our homeless shelter to see patients. We meet them in Dunkin' Donuts. We meet them in Needle Park. Yes, Brockton has something called Needle Park. So we meet them wherever they are. And again, all of our patients get a face-to-face visit, especially right after they've been discharged, but also ongoing as well. Then, when we have them, we assign one of our staff to be the lead. So it's always helpful to have one person who is the lead contact for that patient. And we do that based on what the patient's needs are. So if a patient has more medical complexity or is compromised or more fragile, then we would put either our nurse care manager or our palliative care nurse as the lead for that particular patient. If a patient has more behavioral health needs or more lack of resources, they're homeless, then we would put our social worker as the lead for that particular patient. And that's just a way to divide the work up and to make it easier for the patient to know who their lead contact is. We develop patient-centered care plans with all of our patients. We are fortunate that our outpatient facilities are all patient-centered, certified patient-centered medical homes. So we use the same patient-centered care plan that they use in our outpatient setting. So it's consistent across our system. And the care plan is a very basic care plan from the patient's perspective. And it literally is as uncomplicated as, this is my team who is working with me, this is my care plan, my health concerns are, my treatment provider's goals are, my goals are, what barriers I have or what challenges I have that reach my goals, and then the steps to reach my goals and who's going to help me. And we really keep these simple and down to 3 goals that we're working on at any given point in time. Like any plan, this is a living plan. It is updated as goals are met, new goals come up, situations change. It is a living plan that we update and share with all of the providers who are working with this particular patient. How we serve them is we do whatever's necessary to help them get the services and supports they need in the community. And that is direct assistance with obtaining public, private, community-based services. We provide direct support in the home. We accompany patients to wherever they go, whether it's to their moving into a sober home for the first time or a board and care, whether they're going into a short-term nursing facility for rehab, or they're going home. We go with them, or to their primary care visits. We assist with medications in the home. We do med rec, and obviously help them with getting their medications as well. And then we do a lot of advocacy on behalf of our patients, not only with our community partners and with agencies, but also within the hospital. We deal with patients who are not always the most compliant or the cleanest or the most friendly. They can have outbursts, and we intervene for them in our hospital. We've come in many times to disperse a situation that was going bad really fast. We also advocate internally for how they're treated and how they're spoken to and the services they can get. So advocacy is a big piece of what we do. As I said before, patients participate in our program for as long as is necessary or desired, and we have patients who say, no thank you. In fact, we have a lot of patients who say no thank you right from the beginning. But what we do is we keep them on our list. So if you've shown up once because you qualified for services based on your utilization, we know you, and when you show up in our hospital, we just consider it another opportunity to engage you. And as I said, this is long work because it took them a long time to get into the state they're at. So maybe it's not the first or the 10th time that they meet Mara, that they're ready to engage with us. Maybe it's the 12th time. So we never give up on patients. We're constantly trying to engage with the patients who we know could benefit if they wanted to work with us. And then what we basically do is once patients are transitioned to a more stable living situation, we remain available in the background. So we never graduate patients or close them out of our system. We're always there in the background for support. And what's really rewarding for our team is when a patient will call us and we haven't heard from them in a couple of months. We get nervous that they might be going to another hospital or what happened to them, and they're just calling to say, hey, everything's great. And so that's, again, a very rewarding phone call that we get from our patients. Now, obviously, we can't do this work alone, and it takes a community, it takes a village, as they say. So we have, as Stephanie has said, about over 40 community partners, and these are everything from churches, food pantries, taxis, state-funded services, board and care, short-term nursing facilities, anybody who's going to help us stabilize our patients and provide services and care that they need. It takes a while to build up that number of providers and partners, and the way to do it is just the way we engage patients. It's all relationship building and outreach. So right from the beginning, we were going out and meeting with people and places and organizations saying, this is what we're trying to do, these are the patients we're trying to help. Can you work with us? How do we refer? What's the best way of communication? And then we've done it on each individual patient level. So if a patient needed something in particular, then we go out and we find it for them. We're in month 21 of our 24-month program. At this point, we have established interagency meetings with a number of our main providers or partners that we play with. The two biggest ones are homeless shelter and Brockton Neighborhood Health Center. And we conduct bi-weekly meetings with them where we go through a roster of patients that are mutual for us, and we go through them. Where are they? How are we working with them? Haven't seen Deborah Jean in a while. Where is she? And what do we need? So we're working closely to monitor our patients in the community. As you can imagine, some of our homeless patients, some of our patients with significant behavioral health and substance use disorders are harder to find sometimes, and their lives are in a lot of chaos. So we do a lot of searching for our patients, and connecting with community people to make sure we know where they are and that they're getting what they need. As I said before, we attend meetings or intakes with our patients wherever they are going. So it's always a person-to-person handoff that we're conducting, and if we can do a visit there, we would prefer to do it there, and our patients really enjoy that and appreciate having somebody go with them so then they don't feel as alone. And again, we do a lot of advocacy on behalf of our patients. Just the other day, our social worker was advocating with a board and care who was a little nervous about taking one of our patients because of his CORI background, his criminal history background. And Maura was able to say, we know this patient, I'm a social worker. She talked directly to the other social worker and said, you can call us if anything happens. And they took him in, and I'm happy to say he's been stable there for a month. So that's one example of the kind of work that we're doing. I want to say thanks to the QIN-QIO for reaching out to us very early on and saying, we're doing this work to build community coalitions, and we saw that Brockton was a very needy area, and perhaps you would like to put one together, and they helped us do it, and they're helping us facilitate a state transitions community coalition. And this is where our partners, we can look at things on a systems level. So how are we addressing the needs of our patients within our community? And in terms of working with partners, it's always constant outreach to partners, again, to make sure that whatever our patients need, we're trying to find it and secure it for them. So as Stephanie said, our goal is to reduce readmissions for our patient population by 20% in 24 months. This graph shows how there has been a significant decrease in the readmission rates for this group of patients. You can also see that it's a jagged line. This is not a straightforward work. We have new patients coming into the program, and it takes a while for us to be able to stabilize a patient. It doesn't happen in 30 days very often. It takes 2 months, 3 months, 6 months. But I'm happy to say that the rates have been going down. But we really wanted to look at a deeper dive into what our impact was. So we conducted an analysis of the first cohort of patients 6 months prior to when we started our program, and then 6 months post-program. This graph represents 144 patients that we worked with in the month of October 2015 when we first launched our program. And these are the aggregate numbers of our patients' utilization in the emergency department and then in the inpatient setting. And as you can see, there's been a dramatic decrease. There was a dramatic decrease for this cohort of patients in the use of the ED. And this is really, for us, this is great news for us, since most of the patients that we're working with are frequent users of the emergency room, and that's really not where they should be getting their behavioral health care. They won't get treated for that in our ED or their primary care. So a lot of our work is to connect patients with community-based mental health services and primary care physicians that match their needs. But in addition to the dramatic decrease in the ED utilization, you can see a modest decrease in the inpatient as well. So obviously this work is difficult, and there's lots of challenges. And not that this is the first and foremost, but it is challenging to work with patients who live in challenging, disadvantaged circumstances with significant trauma history, multiple comorbid conditions, and who very often have burnt a lot of bridges. So that makes the work challenging in and of itself. In addition to that, the two bullets there about the lack of state-funded mental health services and the weak system for accessing acute addiction treatment, I think is endemic of our mental health crisis in our country right now. We do not have a robust or adequately funded system for mental health and substance use disorders in our country that meets the needs for our patients. And we are struggling just like every other place in the country. Some of the lessons that we have learned along the way, first and foremost, is to hire or staff up with the people who have the right skill set and the right mindset. And I say you need both. So you need a clinical nurse care manager who's a really good nurse, but who also is really good about engaging patients, who has a strength-based, can-do attitude. How can I help you? I'm not giving up on you. I'm not going to get what some people call treatment freeze. Oh my God, here you are again, and I'm going to go, not going to try again. We are constantly thinking outside the box. Okay, this didn't work. What can we do differently next time? So you need both the skill set and the mindset. And all of our staff, in our program, we take a strength-based, trauma-informed approach with everything we do with our patients. Right from the beginning, like most other programs in CHART here in Massachusetts and in other places across the country, we trained our staff in motivational interviewing, which is an evidence-based strategy for rapid engagement of patients, and it works. We, like other hospitals within CHART in Massachusetts, we have daily huddles in the morning to organize our work, prioritize our patients, who's in the hospital that we have to see, who's in the communities that we have to see, and really delegate responsibilities. This work is all based on the relationships we build with our patients, with providers, with our partners, with the families, and with the community. And it's building and massaging these relationships all the time. This is what makes the work happen. If there's any special sauce in anything about this, it is building relationships. A few other things we've learned, again, similarly to other people as well, you need to target resources for the patients who are most amenable to your services. Doesn't mean you give up on patients. As I said before, every time they're back in our hospital, if they haven't engaged with us already, we're re-engaging with them, and we always see it as an opportunity to work with them. However, there are patients who, for whatever reason, a lot of what we attempt or try is not working or does not work for them, or their life situation doesn't fit for them. And sometimes you have to say, I'm not going to spend an hour chasing this patient when I can spend a half an hour working with a new one. So sometimes you have to target your resources. How we do that is we're now beginning to use the patient activation measure to tailor our interventions based on a patient's level of activation. This is another evidence-based measure to measure a patient's level of activation in their health. How do they understand their health? How are they taking responsibility for their health? And then, more importantly, it helps you coach them based on what level they have. This is a wonderful instrument, and if you need any information about this, I encourage you to ask your quality innovation organization. We've just rolled this out starting the last few months, and we found tremendous satisfaction with using this. And the last lesson I would say is to be patient. Again, this work takes time because the patients didn't get into these states overnight, and it's not going to take overnight to change it around. I would also say, and this is supported by the literature, that your return on investment is going to come in the future. So you won't see it necessarily in the first year or the second, but you will see the return on your investment in staff, and the resources you put for them will come as you get a better handle on working with your patient population. You have to have a good saturation rate in your patient population before you see financially that return on investment. And with that, I'm going to pass it back to Stephanie to open it up to questions, but please feel free to reach out to me, and any question you have that I can't answer, I will forward to somebody who I think could answer it for you. My contact information is right there on the screen.
Great. Thank you so much, Deborah Jean. This is such a great and interesting work that you are doing at Signature Brockton, and I always love hearing about your successes and the lessons learned that you've experienced throughout this process. So we would love to spend the rest of the time taking your questions and also to learn about any similar work that you may already be doing. Nancy, can you remind participants how to submit their questions?
Absolutely. So if anyone would like to ask a question over the phone, you just need to press #6 on your telephone keypad. And additionally, I see some people already doing so, but you're also welcome to ask questions using the chat feature on the WebEx dashboard here on the right. So once again, for the phone, it's #6 for your phone or in the chat box.
Great. Thank you so much, Nancy. And I think we'll start with some of the questions that we have in chat. Naya, do you have a question in chat that you could share with us?
Yeah, we actually have a few. The first one that came in was from Susan Bruce. She wants to know, when you collaborate with homeless shelters, has the patient already signed a release of info in order to share that info?
So we do, so the patients sign a release of information when they are in the hospital, and we engage with them in the hospital, and that release carries us over to the next transition point that they go to. And that's about the extent of what we're doing. We do not have consent forms because we're not a separate program. What we're trying to do in Signature Healthcare is extend the care that begins in the hospital into the community. And I want to be clear that we're only talking about patients who are working with us. So these are patients that we're going to the shelter with, or we've been to the shelter with, and when we discuss a panel of patients, they're all mutual patients that are known between the two agencies and that we have been actively working with. I have to say it's been a wonderful partnership because we get phone calls from our homeless shelter who will tell us, just like they did a month ago, Deborah was found in the church basement. She's locked in the bathroom door, and we think she's overdosed. And we were able to deploy our team and get the ambulance out there immediately to save Deborah. So I guess that's the best. We're just extending the care from the hospital.
Great. Thank you. And I just want to see if there's anyone on the line who would like to ask a question before we get to the next one on chat. Anyone on the line?
Yeah, Stephanie, this is Lorraine from MHA. Can you hear me?
Yep, I can hear you, Lorraine.
Oh, great. I wanted to ask a question about when the CHART grant ends. If you could speak to a sustainability plan moving forward, or what's the next step?
Absolutely, and that's a great question. Thank you for asking that. Our senior leadership in the hospital made a commitment when we were hiring up our community integration team that we were not hiring them to be on a grant, but that we were hiring them as a necessary piece of work that we need to do as the healthcare system around us is transformed. And one of the justifications for keeping our community integration team is that we will be a Medicaid ACO, accountable care organization, in Massachusetts. As of December 18th of this year, we will have about 20,000 patients that are in our accountable care organization, and we already know that the top 5% will be cycling in and out of our emergency room and our inpatient, and we need our team to engage those patients when they're in the hospital. For other people who are not a Medicaid ACO, the justification really comes on your return on investment, and that as we move to a value-based healthcare system, where more and more we're not going to be relying on our fee-for-service dollars, but we're going to be paid based on the outcomes we get, and we're going to be responsible for the financial care of patients. I think over time, more and more places will understand that this is a way to save money on the cost of your inpatient. And one of the things I will tell you that was a really welcome surprise for our CEO, Mr. Kim Allen, is that for the first time, our hospitals did not have to pay a penalty for our Medicaid readmission rate. That we were below where they wanted us to be, and this is the first time for our Medicaid population we did not have to pay that penalty, and he attributes it, as well he should, to the work of our community integration team.
So again, that's some of the ways you can justify the cost of staffing up this kind of model.
That's great. Thank you. And along the lines of the community integration team, there was a question that was sent to just the presenters, and that is, on the community integration team, are there just one person per category, the nurse practitioner, social worker, etc.?
You mean as the lead contact for the patient? We're a team approach, so it's all hands on deck with whatever a patient needs. And we also have, as part of our talk grant, we have another component for pharmacy, and we pull in pharmacists as we need them as well. So it's just to make it easier for the patients that they know there's one person they can always reach out to, and they'll get anybody else involved. And that's a really good question, too, because a lot of the home visits and community visits that we conduct, we do in pairs. One is safer, especially when we're going out for the first time, we go in pairs. But it's also really helpful when a social worker can be talking with a patient about a particular need that they have, and our community health worker is on the phone, she's making calls right then and there, or we have our nurse care manager come out, and there's and the pharmacist the other day was out there with the nurse care manager. The nurse didn't even notice it, but the patient had 2 antibiotic pills in front of them. And the pharmacy tech said, oops, we got to fix this. So that's a great question. We are a team, but on the care plan, when it says who's your lead contact, that's where we just have one person.
And there, what's the next question in chat? And then we'll go to someone on the line. So we'll start with chat.
Sure. Marnie's already asked who participates in the Safe Transitions Community Coalition.
Oh, great question. So we have Brockton Visiting Nurse Association, ourselves, and by ourselves I mean Signature Healthcare and our primary care, and we also are running we run bundles out of the Medicaid contract, and so we have that team there. So we have our Medicaid bundles team there, our outpatient team, and then we have Brockton Neighborhood Health Center, we have Old Colony Elder Services, and we have recently begun to reach out and have our home health care agencies come to this team as well. And it's open. It's open to anybody in the community who is really looking at how do we help patients when they transition between our services. Because as we know, every time a patient transitions from one level of care to another, there's something lost in translation, and there's more of a chance that something's going to get dropped or missed. So we have to pay attention to those transitions.
Yep, and we have community coalitions throughout the state that do involve a lot of individuals from different organizations across the continuum, and it could be anywhere from skilled nursing facilities, hospice, other services, home care, hospitals, and physicians. So we're definitely open to talking with anybody more about that. This is Stephanie from the New England QIN-QIO. If you're interested in starting a community collaborative, we can work with you on developing that. So at this time, I'd like to see if there's anybody else on the line who'd like to ask a question. All right. Great. We'll go to the next question in chat then.
Sure. Leslie Mae Chavani asks, can you please share the patient activation evidence-based measure?
So I will actually take that. This is Stephanie. So we do, part of our work part of the work at the QIO is we do have a license that we can provide to our providers and partners that we're working with on the patient activation measure. So Leslie, if that's something that you're interested in, we can chat offline about that. And I'm happy to also include some additional information about the patient activation measure in a follow-up email.
And I just want to dovetail, it's a really, really simple instrument. It's 10 questions that you sit down and you go through and you have a patient answer. It's automatically scored. It tells you what level a patient is at, whether they're a 1 or up to a 4. And then it has suggestions for how you would begin to work with that particular patient. And it's really based on what the patient's needs are and having small successes that the patient can build their own self-confidence about their health and their health behaviors. And then these small successes will become bigger successes. And actually the evidence on this particular measure shows that those patients who are in the lower categories actually make the biggest gains in their activation into their own health and taking responsibility for that and feeling more confident about it. So I encourage you, if you're interested, reach out to Stephanie.
Great. Is there anybody on the line right now that would like to ask a question?
Hello?
Hello, I can hear you.
Can you hear me? This is Heather Shadow calling in. I'm wondering when it is that your group has their huddle, when you guys meet daily for a huddle. Is that out in the community? And then what people are actually at that huddle that attend? And then do you guys have a template or a formula that you follow during that huddle of things that you discuss?
Great question. 9:30 every morning in our offices, which are hospital-based, we are hospital-based, and it's everybody from the team. I mean, if somebody has an appointment with a patient or something, we try not to schedule that during our huddle because everybody is there, and that includes the whole team. So we have other pieces of our chart grant where we're working with patients in their homes through our Homeward Bound program. Both of those nurses are there. We have our pharmacists, their management team, they are there, and our community integration team. So it's a whole team effort. We don't have a template. We do have questions we follow. They're pretty basic. Who's been hospitalized in the last 24 hours? Of those who are under 30 days, so are readmissions people? Who are we worried about? Who do we need to see in the community? Who do we need to see in the hospital? And then we literally coordinate the work between each other. And our huddles are 15 to 20 minutes long. That's it.
Okay. Perfect.
Great question.
All right, we'll take another question from chat.
Sure. Lindsay Knight wants to know what the caseload is for each of the managers, the care managers.
Great question. It is between 30 and 40, which is high, but those are not all patients that are acute or in terms of, or just engaged, because we do stay involved with them and we follow along on the side. Our community health worker tends to have a higher load. She's up to 50, but that is consistent with most community health workers. Again, the work is a little different for it's more phone calls and transportation. I mean, actually, we couldn't run our program without a community health worker. I just want to say, if you want to do one thing in your hospital, hire a community health worker and put them in the ED. It's a tremendous resource for you. But between 30 and 50.
Great. Is there anyone else on the line that would like to ask a question? Alrighty, Nayara, sorry. We will, another question in chat?
Sure. Diane Block asks, are these patients that are in managed Medicaid programs, how have the health plans partnered with you to make services accessible when needed, not in several weeks?
Excellent question. For our elderly patients, if they're not in a senior care option, which is Massachusetts form of combining the Medicaid and the Medicare dollars into enhanced benefit, we try and get them into that. We work a lot with called Commonwealth Care Alliance for other patients in Medicaid to get them into their program because, again, it's an enhanced benefit for them. And it's really nurse-to-nurse care manager who's going to do what and how can we, get services for this patient as soon as possible. And this is all advocacy. This is relationship building and advocacy. And we do it on a patient-by-patient basis. We've also, I have to say that the health plans have been really wonderful partners for us, and they've come out and they've met with our team. And they want the same thing that we want. I mean, the modus operandi is keep them out of expensive care. So if we're all working to keep them out of acute care facilities and not coming to the ED to get primary care needs met, then we need to do that.
Thank you. This is great. This is a really great discussion that we have going on, and I just wanted to remind those on the phone, if you do want to ask a question over the line, to do that, you press #6. So I'll just pause for a second, see if there's anybody that would like to ask a question on the line. All right, Nayara, we'll take the next question in chat.
Sure. Leslie Nechvani has another question. She asks, what are your findings around patients with malnutrition risk, food insecurity issues as a social determinant of health factor and related to behavioral change and dietary compliance?
So, great question. Leslie, thank you for that. Brockton actually is designated, I think we have 8 what they call food deserts in our city, which means that a person can't get to fresh foods and affordable food on a regular basis. We have a number of things we're doing with this. I mean, this is a huge issue. One is that Brockton Neighborhood Health Center has just partnered with a local supermarket. They actually have an off-site an offshoot of Brockton Neighborhood Health Center in the Vincenti's food store, where they have cooking classes and patients can come and they sign them up for SNAP, which is our supplemental nutrition program, or WIC if they need WIC. So that's one thing that we're doing for our homebound patients. We actually have a grant where we have our nursing students that will deliver meals to them 5 days a week. And we have a cafeteria that puts together lunches for our patients, and our nursing students deliver it to them. But that's just scratching the surface of this problem. It is a big problem. We partner with food pantries. We have a wonderful church, especially for our homeless patients, that provide lunches and meals there whenever they can. They're not 7 days a week. That is a problem. And I should say, if you come into our emergency room, we make a wonderful turkey sandwich, and our patients rave about it. So sometimes we have to find another place where they can get their turkey sandwich. We do have petty cash that we have used to purchase a cup of coffee for patients, and get them not to leave against medical advice. Mostly we use it for transportation, bus passes, but if they needed some food immediately, we would do that. And again, we partner with our food pantries and to make sure that we do the best we can. But it's a big problem, and thank you for asking that question.
I don't know if I want to visit the emergency room to get a turkey sandwich, but yeah, sounds nice. So let me just pause here and see if there's anyone who is on the line. Again, it's pound 6 to unmute yourself. All right. And if you did accidentally unmute yourself, you might want to just hit manually hit the mute button. Otherwise, we'll go to another question in chat. Diana.
Sure. Cheryl Leary asks, can you talk about when you use the patient activation measure within your patient interaction? Is it during the ED visit or first home visit?
Yeah, it is not rather in the hospital. It's not, there's too much going on, and for some of our patients, they're literally detoxing. So it is definitely either the first visit or the second visit. I mean, it's really after we've engaged with them, and you want it to be a conversation with them. We don't want to interrogate them. Hey, we're going to give you this 10 questions. Tell us how you rate yourself on this. So, but usually, I would say within the first 2 weeks that we're working with a patient.
Okay. All right. Is there anyone on the line that would like to ask a question? All right. Moving down the chat, Nayara.
Sure. Patricia Burke asks, what is the community health worker's background?
So our community health worker has worked in our hospital for 35 years. This woman knows this hospital inside out and the community, by the way. She's from the community, which is one of the things you need to look for in a community health worker, is someone who lives in the community, knows it well, and has relationships already that you can build upon. But secondly, she was for the last, I'm going to say 5 years, our patient advocate. So whenever there was a complaint about something in our hospital, she was the person that they put on the line. And after doing that for 5 years, she came to the director of the social work and said, I want to be part of the problem, part of the problem, not part of the solution, not part of the problem. I really want to work with patients one-on-one. I know that they can get dissatisfied with things, and I would rather be on the other end of it. And it's been, again, tremendous. She is not clinical, and she doesn't have a bachelor's, but she's one of the most, she's our linchpin, really, because she has an incredible can-do attitude. Let's try this. I know this person. Let's call that person. And if you met her, you'd love her immediately.
That sounds great. I'm just going to see if there's one more question on the line. And Nayar, is there any other questions in chat? It looks like we did cover them all. And I did want to also follow up on the PM. What we can do is I can send out a fact sheet on what the patient activation measure is, just so that you have more information on that. I saw that there was a lot of interest in that, so we'll be sure to include that with our follow-up email. And we also have it on our website. I want to thank Deborah Jean for a wonderful presentation. This was a great discussion too, so thank you everyone for all of the questions that you shared with us. We have a number of medication safety and care transition programs that are coming in the next few months. So more information on these and many other programs can be found on our website under the events section. And then I'm going to turn it over to Nancy.
Sure. Hi, everyone. So just a reminder, please be sure to follow the New England QIN-QIO on social media. You can visit us on Facebook, LinkedIn, and YouTube. Here you'll gain access to updates and information on upcoming educational events, various announcements, tools and resources, and much more. So be sure to check us out and follow us if you aren't already. Also, when you close out this webinar today, an evaluation for this session will automatically pop up on your computer. We really encourage you to fill that out so we can get your feedback. If you don't have time to fill that evaluation out right now, or if you're currently sharing a computer with someone else, you'll also receive an email soon, which will have a link to the evaluation as well as a link to the event page on our website where the presentation is stored. However, Nayara has actually included that link in chat as well right now, so if you wanted to access that, you could certainly get the presentation now. Or it's already up on our website on the event page, as I mentioned, healthcarefornewengland.org under the events tab. The presentation is there now, but in the next few business days, the recording and a transcript from this webinar will also be added to this page for you to download. Thank you again for attending, everyone, and have a great day.
The reader has disconnected. The conference will be terminated in 5 minutes.